So let's get to the reason that you are actually here, and that is to discuss muscle stretching as our topic for today. To tell you a little bit about my background, I am a therapist back from the bachelor's degree days. I've been practicing for 25 years, long time, and enjoyed experiences in many different settings. So I'll try to pull different examples for you as we go through the course. I've practiced in acute care, outpatient, adult and pediatric, in-pad, individuals with head injury, spinal cord injury, amputations. I've seen pediatric care across the continuum from the neonatal intensive care to outpatient therapy, home care, as well as school-based. And I have also, living in Florida, worked in the skilled setting, which has changed. It's more rehab-based, so a lot of what we're discussing today are those going to be applicable to that cohort of patients. And in my therapy career, I've also enjoyed being an educator in a physical therapist assistant program for many years. So I hold my master's degree in education, specializing in online teaching and learning. So this fits very well. And I look forward to a enjoyable session with all of you this morning as we work our way through. To give you a little bit of information on what we're going to learn today, stretching is something that you are utilizing constantly in your day-to-day interactions with patients. And it was an opportunity for myself also in my practice to look at how I'm performing stretching and say, are the techniques that I'm utilizing and the way I'm applying them still consistent with the current evidence? Because there is so much research mounting out there in all of our fields of practice that I wanted to do a little comparison to see, do I need to tweak my interventions to be more effective? So we're going to take a look at stretching and specifically consider it kind of going back to basics. We're going to look at the different types of stretching, really analyze the physiologic effects that we're trying to elicit so that we can choose the best intervention at the best time to achieve our patient goals as they return to function. And we're going to particularly consider individuals across the lifespan. We will use pediatric examples as well as your typical middle-aged or younger individual, and then our older population. Living here in Florida, I can tell you the recreational sports that patients participate in, and I just see individuals participating in, is at a higher level than some of the competitive sports I see of the pediatric and young adult population. So we have lots of ways that we can be applying these interventions. And then we also are thinking about stretching on the other end for our patients who maybe have more of a functional decline or they're rehabbing from an injury and they're in earlier phases of recovery. So we'll use examples from both, again, to help you decide if you need to tweak your interventions or if what you're doing is already effective. I think it's beneficial sometimes to go to a course and walk away with certain pieces of information where I say, yes, I'm going to keep doing that, it's correct. And then other pieces of information that you can apply to be specific to your populations. And I think you'll find we'll tackle all of that today. When you go back into the clinic tomorrow, you're going to apply these concepts in accordance with your federal, state, and professional regulations. So you'll use your professional judgment as you apply these techniques. Our schedule for today is your typical CEU schedule where we have a 50-minute hour. So at about 10 of every hour, I will definitely give you that break to refill your coffee or just stretch, check on the kids, whatever you might need. And then around, as I said, the 12:40 time period, we will come to a consensus on the correct answers for the post-test so that then you can go complete the post-test later on today, submit your payment, and your CEUs are going to be. What we're going to focus on today, as I mentioned, is stretching. And it is such a broad topic, so I had to somehow scale it down to fit just in our 3-hour time frame. What we're looking at with stretching is really considering patients with range of motion restrictions, where they have decreased flexibility of the muscle, not allowing that joint excursion to perform their functional tasks. And it brings up the question that, well, what type of stretches should we be performing, and when during our therapy sessions should we be utilizing them? We're going to take a look at a lot of the different research that's out there. When I look for studies, I don't stick only to our physical and occupational as well as athletic training journals. Those are great and beneficial and very clinically relevant for us. There's an additional whole body of information out there internationally from different science and research journals, particularly on this topic, a lot of bioengineering. Some of physics journals I found were considering torque and length and the physics of things. So a lot of the references that I will mention, the research is coming from a broad spectrum of studies to piece it all together and kind of translate it for you to be applicable. All of the studies that I utilize are ones that are readily available for free out there on the internet. So if something in particular you find interesting, when you go to the back of the presentation, the last several slides list all of my references so that you can go read them a little more in depth if you so desire to get a little more information out there. When we look at our decreased range of motion for our patients, what we are going to be considering is, as I mentioned, that for whatever reason, the patient is unable to, lift their arm up overhead in order to, perform their ADLs, or in order to lift those packages if they're trying to return to work and they have to stock shelves. If they have a decrease in their range of motion and flexibility, there are many reasons that this can happen. Possibly they have a specific pathology that involves the joint, maybe osteoarthritis, or they have ligament and tendon pathology that is restricting their range of motion. We also see patients following orthopedic procedures if they have undergone a total joint replacement, or if they have had a tendon repair. During the various stages of healing, we need to exert certain forces across that repair and those structures in order to facilitate their healing. We know that as individuals age, we can see range of motion restrictions. Specifically, our flexibility, it's sad to say, it peaks when we're in our early 20s, and then it's a steady decline from there. Not that we can't counteract that with our interventions, but we tend to see over the lifespan that there's decreased elasticity of the various soft tissue structures. We have synovial fluid changes, cartilage changes, all of which can impact range of motion and flexibility, as well as the muscle itself can become less elastic to allow that joint excursion. Some individuals may have decreased range of motion because of muscle imbalances that develop over time. Think of that individual with their rounded shoulders, those tight pecs. Maybe they don't really work out their rhomboids and middle trap well, so those muscle imbalances develop that lead to altered mechanics of the joint. So we have many different reasons why a patient may have decreased flexibility and range of motion, and in all of those instances, our goal is to restore their normal alignment and range so that we can continue to allow them to function or move them back to more appropriate range of motion and functioning. And we have many different factors that are going to contribute to this. When we look at what factors contribute to this decrease in joint excursion, we're looking at several factors. If we consider on the top half of our screen, get my cursor here. Here we go. 1 second. Get my pen. So if we look here at the top half of our screen, this chart, if there's decreased range of motion, it's for two primary reasons. Either the joint structures are not allowing the movement of the joint surfaces, or the muscle is not allowing for the excursion. It doesn't have the appropriate length. When we think about the joint and its structural integrity, we're considering all those periarticular structures. So we have our glenoid fossa, we have our humeral head. Surrounding that, we have our joint capsule, we have the ligaments, those other structures that can become tightened down, not allowing for joint motion. those specific interventions to target that tightness are going to be different than what we're discussing today. Where we're focusing is kind of on the next layer out, our muscles that are surrounding those joint structures that need to have the length and the elasticity to allow the joint surfaces to glide. When we consider muscular tightness, there are two aspects that contribute to the muscle not lengthening appropriately for the joint to move. We have both passive and active mechanisms. So let's say your patient has significant shortening down of the muscle, that it's actually adhered down. Maybe there's scarring because of an injury and there are adhesions in that muscle. Or they have a muscle spasm that's not allowing the muscle to lengthen. That's going to be related to our muscle tightness. When we take this a step deeper into the physiology, looking down here at the bottom half of our chart, we're going to recall that basic anatomy of the muscle and try to consider, well, what happens when that muscle is tight? What factors are contributing to that tightness? And we have active and passive tension in our muscles. Our active tension is going to relate to more of a neurophysiologic aspect. You're looking at our alpha motor neurons, our Golgi tendon organs, our muscle spindle, those things that are not under voluntary control, more of our reflex mechanisms. And then we also have passive tension mechanisms, which are more of our mechanical properties, the structural integrity of that muscle itself. So the two factors of the structural integrity of the muscle from a physiologic perspective and the neurologic control of our muscles are going to play a significant role in our effectiveness in allowing that muscle to lengthen to restore its range of motion. So in breaking down this physiology more specifically, we have our active controls of our neurophysiologic components, and then, as I said, we have our passive controls of our mechanical components. We're looking at the fact that our muscles respond in different ways, that we have reflexes that are going to play a role in the tension of the muscle, and then we also have the viscoelastic properties, the structure of the muscle itself, that plays a role in its ability to lengthen and stretch. And when we apply our interventions, we need to be cognizant of both these aspects so that we leverage them to be most effective. That's traditional, right? That's a scary flashback to physiology from school. We're going to look at them based on the current research. And there's another aspect to this that the research is emerging, saying, you know, there's another factor that we really need to consider, and that is stretching tolerance. That the idea, and it's kind of like, does a tree fall in the forest? If no one's there, do you still hear it? Does it still make a noise? it gets a little bit into that, but it makes sense if you stick with me. The thought is does the patient have a specific tolerance? Does their cognitive perception of the stretch that they're feeling, of the sensations from their nociceptors, their proprioceptors, mechanoreceptors, all that input to their central nervous system when they're having a stretch, does that play a role in how much excursion is permitted? Do they almost cognitively say, well, that's enough of a stretch. Okay, don't go anymore. That's uncomfortable, or I can't take anymore. Is it stopping them before they reach the true end of the elasticity of those structures? And it's something to consider, that some of the studies have actually looked at this to say, is there more left in the elasticity of the structures than the patient can allow? And this is important to remember, because think about yourself. How do you decide where to hold your stretch at the end range of motion? Just think for yourself for a minute. The last patient you performed stretching on, whether it was, those triceps, if you're trying to get elbow flexion, or those hamstring length, how did you know where to take the stretch? You take the slack up, and then many of you may stop when you feel the slack is up. Others of you may say, well, I get feedback from the patient. I want them to tell me, are they actually feeling a stretch? The research is saying, because this stretching tolerance is a factor, that we really need to take that to a point of the patient feeling discomfort but not pain. That we really need to make sure we're pushing to the true ends of the range of motion. And the more we can have the patient cognitively relax, maybe close their eyes and not think about it, and just tell us when they feel that stretch, the more effective that we can be in our interventions. So that's an important piece for us to know, and that might be the first modification that you make in your interventions. It really needs to be a combination of what we feel, but you have to have that feedback for your patient. When you're performing your stretch, we're considering all these physiologic factors that are going to be occurring. We're thinking about the soft tissue, and what the research is finding is that there are definite times that you should consider using one type of stretch over another, a PNF stretch versus a static stretch, and understanding physiologically what happens when we stretch and the tissue's response is what's going to allow you to make that better decision. That our routine should not be the same routine for every patient in terms of our types of stretching, just like our exercise should not be the same for every patient. That we really need to be altering it throughout our day and for each patient to be most effective for them. And the first aspect that you're going to consider as you're thinking down to the physiologic level are those neurophysiologic responses. We're looking at this physiologic stretch reflex, and I promise I will make slim this down. I know we don't want to be back in that college classroom dozing off related to physiology. I'm going to give you the skinny on this for what you need to be thinking of as you're performing those stretching interventions. So we're going to go back to that basic monosynaptic reflex arc. We know that in our muscle we have the muscle spindle, and the muscle spindle is located in the muscle belly. It's a long, thin nerve receptor in the muscle that it senses changes in length of our muscle. What happens when the muscle spindle senses a change in length is it sends a signal up to the spinal cord, to that dorsal ganglion, and then that signal transmits at that same level of the spinal cord to come back down the efferent fiber to cue that muscle to contract. So we have the muscle spindle senses a length change, sends the signal up to the spinal cord, afferently, our effect coming down the motor neuron is that there's a contraction of that muscle. This is our basic reflex arc. It is designed in order to sense resistance to movement and be protective, so that if a muscle is being stretched past its limits, the body is going to then contract that muscle down to protect the joint and to limit the trauma that can occur. So it's going to develop that tension and that resistance to change through this monosynaptic reflex arc. And this is important that we have this intact. What happens is when a muscle shortens down because of pathology or disuse, whatever the reason, that muscle spindle now thinks that the shortened down length is the new resting length. So anytime we try to stretch beyond that, you could potentially trigger that muscle spindle, and it's going to say, no, you can't go there, contract it back down. What happens as we try to overall gain muscle length is we need to overcome this reflex activity so that we can truly make gains. Or if you're returning someone to a sport or an activity where maybe they need, it's new activity for them and they need better range of motion than they had before. They need to condition themselves to have a longer excursion of that joint. So our hold times are really important at that end range of motion, because envision that you're trying to overcome this muscle spindle firing to allow for a greater range of motion. It's also the reason that everyone knows we should not do ballistic stretching. What's the first thing you learn about stretching in school? No ballistic. Don't bounce at that end range. When we have that bouncing stretch at the end range, it's actually triggering this muscle spindle firing, and the muscle is going to try and contract down. But if the individual is still holding a stretch, you have the reflex activity saying, okay, shorten down, contract that muscle, but you have the physical mechanical force of the person holding at the lengthened state, and now you have potential trauma to the tissues with that stretching. And particularly, we really need to be cautious of this in our older population, because it can create even further increased trauma. So it's important to know that when we're educating our patients, that we really make sure that they're not ballistic stretching. I still, unfortunately, and many of you may see it, if you go somewhere and you see people working out or before their sports activity, I drive past the tennis courts in my development, I still see ballistic stretching. And it's so important to educate our patients to avoid this. And this is the reason that we're trying to overcome that firing of that muscle spindle to avoid trauma to the structures. Another aspect, in addition to the muscle spindle, is the Golgi tendon organ. The GTO sits in a little different location in the muscle. This is another receptor that is going to be located more at the musculotendinous junction. And the Golgi tendon organ, again, is going to be a sensory receptor. But in this case, it senses the force of a contraction in addition to length. And it is going to recognize that there's a forceful contraction occurring in a muscle. So we'll have that Golgi tendon organ sensing that there's a forceful contraction. It sends that perception back up afferently to the spinal cord. But in this case, we are going to have an inhibitory neuron that comes back down, and that is going to tell that muscle to shut off. It's going to trigger the opposite reaction of the muscle spindle. The Golgi tendon organ, when it senses a contraction that has a significant load and force to it, it's going to send a signal back down to that muscle to shut that muscle firing off to avoid injury. We can use this to our benefit in stretching. This fact that we can contract a muscle and bring it to enough of a forceful contraction that this interneuron tells it to relax is the premise of autogenic inhibition that we use with PNF stretching. That the body is trying to protect itself in order to cause relaxation of the muscle. So why not use that to our benefit when we talk about PNF stretching for our patients? The Golgi tendon organ also plays a role in reciprocal inhibition. To refresh on that, it's our idea that when one muscle is contracting, the antagonist is relaxing. So for example, if I am contracting my biceps for elbow flexion, we know that my triceps have to shut off in their firing to allow for their muscle length as those biceps are contracting. This, again, idea that we're reciprocally inhibiting the muscles, that contraction of one muscle can force relaxation relaxation of another, we can utilize in different types of stretching to allow benefits for our patient. All of those various neurologic responses that are occurring are aiding us in our stretching. And this is what you should be considering as you're applying your different force and you're making your stretch selections. We'll go over them specifically. The secondary aspect that I said, in addition to all of those active control mechanisms, are our passive control. What is actually occurring at the cellular level of the structure of the muscle itself, looking at those viscoelastic properties, because we do need to have a structural change if we're actually having new length. Right? That muscle needs to somehow become longer and maintain that in order to allow for increased joint excursion for our carryover to function. Going back down to the cellular level, we're looking at that our muscle is consecutive bundles of muscle fibers, then myofibrils, and then eventually we're building out to our entire muscle. All these tissues are going to respond to stretch. That this muscle, as we apply the force, it is going to deform based on the force that's placed upon it. That we need to apply that force for a long enough time with a sufficient load to actually create changes in length. What happens is, as we lengthen it and we apply that load force, we can make gains, but over time we see that the muscle tends to creep back because of the elasticity of it and the viscosity. It's going to shorten back down. So our stretching, we know, we need to continue with it over time to make our overall gains in range of motion. We need to overcome that creep. Creep is when we have the lengthening of the muscle, but then over time it starts to shorten back down. Since we know that that happens naturally, ultimately, we can make gains in range of motion, so there must be other factors that are contributing to allow us to make better gains. And I mentioned already that the first thing to consider is stretching tolerance, that are we truly in our hands-on technique or the patient's self-stretch, are they reaching the true end range of motion? Are we applying that force at the right location to make additional gains? And that is where the stretch tolerance comes in. You must have the feedback from your patient to make sure that it's they're feeling discomfort with their stretch, but it's not painful. That's where your stretch needs to be applied according to the research to really make the actual gains. And it was interesting, several studies looked at this and they found that if they were doing EMG studies of the different muscles, they had patients where they were performing knee stretching and they put EMG electrodes on the patient to ensure that they were relaxed. And they measured the joint excursion with the patient cognitively aware and looking at the limb, seeing the excursion. Then they measured it with the patient closing their eyes, relaxing, and just trying to allow the joint to go as far as it could and bringing them to that point of discomfort. And they found that the patient was able to achieve greater range of motion. So it brings us to consider that maybe there is a little bit something to be said about stretching tolerance. So making sure the patient is relaxed, having them not cognitively thinking or looking at the number that they're achieving, because it may actually be inhibiting their Our physiologic effects of stretching that we are trying to achieve are looking at what's called stretch relaxation. That, okay, this idea, yes, we have a viscoelastic property. We need to make that muscle lengthen. We also need to make sure the patient's relaxed and supported and they're not cognitively, right, our total joint replacement patients. I have to get to 100 because the person next to me got to 95 and I want to beat them. Well, you know what? That might actually be impairing their range of motion. Even if we account for all those factors, there is still other reasons that we can make gains. Physiologically, there are other changes that have to happen to get that muscle length. So one particular study said, okay, stretching tolerance makes a difference. If it was really just related to this reflex arc and the perception from the nerve, what they did was in rabbits, they looked at the extensor digitorum longus and the anterior tibialis. And on one side, they denervated it, and on the other side, they left the nerve intact. So principles we talked about up to this point, they said, let's compare. They applied the stretching techniques and they found that the tensile force changes, that the range of motion changes. When they applied the same stretching, they were still able to make gains in both the innervated and the denervated muscle. So this was one study that said, you know what, the viscoelastic changes that are happening, the structural changes to the muscle, there have to be other factors, other chemical reactions and things that are happening that lead to the lengthening of the muscle. And what it comes down to are these cellular adaptations, what's actually occurring. When we remember back to our sarcomere, if we look at that basic unit of the actin and myosin that need to overlap for contraction, but then they also need to lengthen in order for us to have joint excursion and flexibility, that if someone has a period of immobility or they are not activating their muscle fibers or they're not being stretched, they are finding that there's actually a change in the sarcomeres, that they shift and that they do not allow as much range of motion to occur. This led to research looking at, well, what actually, if they shorten down when there's not muscle lengthening, then somehow they must get longer, they must grow. There has to be sarcomere genesis that occurs in order to restore the length and the range of motion. And what they found in some of the research is that these sarcomeres can actually change at the microscopic level when stretching is applied. And they looked at the microscopic level, analyzing the sarcomeres, these individual units, and they found that when stretching was applied, that there were new deposits made to allow for lengthening of the sarcomere. And then over time, if you look at the larger scale, that allowed for greater excursion and muscle length. This is the whole theory that bone lengthening is based on. That when individuals have bone lengthening procedures, it's a mathematical calculation that's completed to determine, well, how much bone length can occur, and then they have to wait a period of time for the muscles to lengthen along with that. Because what they found is that the body is always going to try and restore that length-tension relationship. That when we have actual lengthening of the muscle, that new sarcomeres are going to be deposited to try and restore that length-tension relationship. And the thought is that when we have muscle stretching, we're tapping into this same idea because we're applying a force that's then going to allow these sarcomeres to generate, to allow for greater length. Another thought is based on satellite cells. And these are very fascinating cells. If you've taken other courses with me, you may have heard that I bring them up whenever possible just because I find them so interesting. That if we look at the individual myofibril, around the outside of it we have a thin membrane, and sitting on that membrane are located these satellite cells. They're myogenic stem cells, and what they find is they sit there quiescent. They are not activated. They're not really doing anything because their job is to regulate muscle growth and regeneration. So they activate and turn on to help regenerate muscle when there is injury or pathology. So they are going to really function to repair the muscle. And what they're finding is as they are activated, they are going to migrate along the fiber. They're going to allow repair of that tissue. And they've actually seen that there's increased protein synthesis that occurs. And stretching in and of itself, they found that it is going to increase the proliferation of these satellite cells. So if we have greater proliferation of these satellite cells, that means there's more of them present in order to repair and help lengthen that muscle tissue to move us toward our goal. So I like to think now when I do my stretching that there are all these other reactions occurring. And when we talk about how long you're supposed to hold a stretch for, it really does make a difference. If we're, supposed to be holding that stretch for 30 seconds and maybe, it was held for 15, or our patient, when we're giving them that home program and we ask them to reproduce and perform it in the clinic and they show us that they're only holding for 10 seconds, but it's supposed to be 30, that this does make a difference because all of these physiologic changes that we are discussing may not be happening. And that's why it may not be effective. And where understanding the physiology is so important because that's what's really making the difference. It's not just the stretch, it's that the stress triggers all of these physiological responses. In looking at some other responses that occur, we have several different chemical reactions that are going to contribute to this cascade of effects that lead to the satellite cell activation. And to just get into it briefly, because again, it gives us a sense that when we're holding those stretches or we're choosing which stretch to utilize for our patient, that there's a lot happening beneath the surface that we need to be aware of. And what they found is nitric oxide plays a significant role in the effects that activate satellite cells. And the way they discovered this is through crush injuries in mice. When they blocked the nitric oxide, the satellite cells did not have their cascade of activation. Also, they found that our calcium channels play a significant role in encouraging these satellite cells to enter their repair cycle to allow for the muscle lengthening. And they found that this extracellular calcium kind of having an influx into the cell membranes will trigger the satellite cells to activate. And again, it's important to remember that we have specific parameters of our stretching that allow these effects to occur. And when we move forward into the next hour of the presentation and we talk about the different types of stretching and the hold time and when to use the different types, that all that research is based on the idea that we're triggering these different responses. There are many different types of stretching that we can utilize for our patients in order to achieve our outcomes. The research is very interesting when we go through it. There is different terminology that's utilized by clinicians compared to researchers. And it's important to remember that whenever you're looking at a research study, especially with our push for evidence-based practice, that when you're reading that actual study, that you understand what interventions they're performing, that we can't just take the names of the techniques at face value, especially if you're looking at research from disciplines outside of therapy. So what I've done is compiled from the different research studies that I've read, and I think for this particular presentation, I read about 70 different studies, so trying to pull terminology and translate it for you. We've been able to categorize stretching into 4 main types of stretching that can elicit these different effects. We have passive stretching, active, dynamic, and PNF. Again, different researchers may utilize different terminology to refer to the stretching, so I caution you when you pull studies to always go to that methods section and take a look at actually what was performed so that you're comparing the information to your current knowledge base in an appropriate way. That'll make it easier for you to learn how to apply it. Our first type of stretching is passive stretching. This is our most common static stretching that we think of, where as a clinician, we're going to go in with our hands on the patient, move them to the end of the range of motion, and hold for our stretch. It could be performed by the patient or the therapist. Patient's completely relaxed. There's no muscle contraction that is occurring. It tends to be a very gentle type of stretch, meaning we move into it slowly. And we know now we're going to bring the patient to that end range of being just short of their pain threshold. And clinically, we're going to document this as our manual passive stretch, our self-stretching for the patients. You're commonly utilizing this post-surgical, post-injury during our rehab techniques. This is also a type of stretching that is utilized for patients when we look at return to function or return to wellness and activities. And what's going to be important is the timing of this passive stretching. It's our most common type of stretch that we probably utilize. And after today, you're going to think a little bit more closely about when you apply it in your therapy session and when your patient is going to perform it post-rehab to maximize its benefits. We have 3 other types of stretching that we're going to discuss, our active, dynamic, and PNF. To make sure that everyone understands the different types of stretching that can be performed as we move into our next hour when we look at when to use each one. Our first type of stretching that we discussed was our passive stretching. So this is your typical manual type of stretching. For example, I can show my arm here more easily. So let's say a patient has lateral epicondylitis. So we are going to stretch the wrist extensors. So manual, passive, or self-stretching would be either the therapist or the patient. We elongate that muscle. This is 2 joint muscles, so we're going to elongate it and flex our wrist down and just hold that stretch. A wrist flexion for the patient, and then let up and move into our next repetition. So that's your typical manual passive stretching that we can perform at any joint in the body. The next type of stretching is active stretching. This technique is really rising in popularity, and what we see with active stretching is the patient is performing this stretch. It's not a self-stretch, because self-stretch and manual stretching implies that the patient is relaxed. There's no muscle contraction involved. Active stretching is going to involve the patient moving their joint into a position. They're going to hold that position in order to allow muscle lengthening to occur. And the best example, if you think active stretching, consider yoga. It's a great example of active stretching. So let's take a look at the picture on the top right here. So this woman is moving her left limb up into hip flexion. So her iliopsoas here and her rectus are pulling her up actively into hip flexion. So she is contracting her iliopsoas and her rectus femoris. As they are contracting, we are going to see reflexive inhibition of these hamstrings and glute max, because again, reciprocal inhibition, when the agonist is contracting, the antagonist is going to relax. So this whole time, those red flexors are firing, our blue extensors are relaxing, and that's going to allow for more progressive range of motion to occur as that position is held. So this is your active stretching, and it works on the principle of reciprocal inhibition. The next type of stretching we're going to look at is dynamic stretching. And this may be new for some of you who may not be working with athletes. The visual that I can give you is, if you've ever watched a sport competition, you'll often see the athletes do what? They'll run a couple of laps, and then they will come back to their court region, and they'll move through a series of body movements up and down the court in repetition. And what they're performing are their dynamic stretches. These are techniques. I'm going to pop up a video of what dynamic stretching looks like. Dynamic stretching, we're looking at the individual moving through a series of maybe squats as progress, or lunges progressing up and down the court, arm swings, knee kicks, heel kicks, different movements in high jumps, in series as they progress up and down the court. And the idea with this dynamic stretching is that they're going to do, 5 to 10 repetitions of several different motions, lasting several seconds to minutes each. And as they perform these different motions, every time they do that high knee kick, the next repetition, they're going to go through a greater range of motion, because their body has employed autogenic inhibition. They've contracted the muscle, so it's going to relax. So the next repetition, it's going to go further. It's utilizing reciprocal inhibition, again, because we're contracting the agonist and the antagonist. And the idea is that the patient is controlling the range of motion, so it gets in that patient tolerance perspective. And over time, it's going to progressively increase their range of motion. It's not ballistic stretching. When the individual is performing, let's say, their arm swings, I'm not bouncing at the end range of abduction or flexion. I'm taking myself through this range of motion, and as that muscle warms up, as I contract it and relax and then contract the agonist, it is going to allow progressively for greater range of motion. Dynamic stretching is something that a lot of participants after the course say it wasn't a technique that they had considered for their patient population, but they're starting to implement it because it's not just your athlete. Think of your patients who are returning to any functional activity or recreational sport activity, I should say, where they are going to participate in a sport and need to perform stretching beforehand. Dynamic stretching, we're finding, may be a better choice than static stretching, and we'll talk about why. So it's not just your competitive athletes, it may be your recreational athletes that you're utilizing this for, because return to wellness is such an important part of our rehab for our patients. And finally, we have our PNF stretching. Our PNF stretching is going to incorporate the use of a submaximal contraction. So a joint is taken to its end range of motion. There's a muscle contraction at that end range, and then we progress into our new range of motion. The idea with PNF stretching is that that submaximal contraction is going to allow for greater relaxation and stretch, so more range of motion gains after having that isometric contraction being engaged. One example of PNF stretching is contract relax. Some of you may know of it as autogenic inhibition. The idea is, I'll use my arm because we can fit it on camera here. So if my patient has tight triceps, I will take them to end range of motion elbow flexion. Since those triceps are tight, I'm going to ask the patient to engage that tight tricep. So they're pushing out into elbow extension and I'm blocking it. So they'll do an isometric contraction of those triceps. Then they're going to relax and I'm going to move on to my next stretch. And then repeat that. They'll contract those triceps, trying to push out into elbow extension, but I'm blocking it. So it's isometric. So as that patient is isometrically contracting these triceps, we are inhibiting that muscle. Remember, we said that that Golgi tendon organ is going to sense the tension and then cause it to relax, and then that'll allow me to make a greater gain in my range of motion. What they found with the level of isometric contraction, there was one particular study looking at, they used males between 18 and 27 who were healthy, but they were trying to decide, well, what intensity isometric contraction is needed for this PNF stretch to be effective. And they compared a 20%, 60%, and 100% maximum voluntary contraction to see if it influenced the range of motion gains. And what they found is at all of the intervals, there was some gain, but for the most part, they're saying to stick with a submaximal isometric contraction. You want your patient to move to a point where they're contracting that muscle with enough force, maybe about 75% towards their maximum, because the concern becomes delayed onset muscle soreness. If you are utilizing too much of an isometric contraction for a muscle that's very weak, you may be triggering muscle soreness that then does not leave that muscle available for the other components of your rehab. So that's where you have to be a little bit cautious with your stretching. The idea I mentioned of why this type of stretch is effective is because the Golgi tendon organ is going to allow that muscle to relax further. Another idea is that there's this thing called the Hoffman reflex. And the Hoffman reflex is looking at that immediately after a muscle performs an isometric contraction, there's this very small window of time where that muscle has a decreased ability to activate its motor units. And it takes, from 1 second to maybe 5 seconds before it can activate those motor units. So it says when you do your PNF stretching that you should always be holding at end range and do your isometric contraction right there so that you can immediately go into your next portion of the stretch while that Hoffman reflex is decreased so that muscle relaxes even further. So usually when we do our PNF stretching, you're going to end range and then do maybe 3 repetitions of the stretch, holding each one for 10, 20 seconds, let off, and then repeat that several times to compile your stretch. The other way that you can utilize PNF stretching is to engage the opposite muscle of what is tight. So we can use either hold, relax, agonist, contract, it may be referred to, but the idea is that it's employing reciprocal inhibition. So if my patient has those same tight triceps, but let's say that the pathology they present with, their triceps are extremely weak, and I do not want them to exert that muscle endurance and power just for the purposes of my stretching, I might choose to utilize my biceps. So I'll take that patient to the end range of motion, and then I'm going to ask them to actively contract their biceps against my isometric contraction. And then when they relax, I'm going to still pull them into that tricep stretch. The idea here is that when I'm contracting my biceps, I'm reciprocally inhibiting those triceps. So they're going to relax to allow for a greater stretch. Different types of techniques that we can employ for our stretching in order to make gains for our patients. So there are so many different ways, that we can employ our stretching. There are many indications for stretching, and traditionally we're going to utilize these different techniques to restore range of motion and function for the patient. And in our healthy populations, we're looking at flexibility, muscle soreness, improving function. And traditionally, this is what many of us learned in school as our indications for muscle stretching. When we look at the current evidence related to these factors and whether or not our traditional views still are the appropriate way to think about our interventions, what we need to consider are the types of joints that we're applying the stretching to. Interestingly, the majority of the research that I found that's out there was performed on healthy subjects. There's a significant amount on injured populations, but it doesn't cover every pathology that we're seeing and every joint. A lot of the research is on the hamstrings and the gastroc, maybe because of ease of performing those interventions and stretching to them. So with a lot of it, we're translating what has worked in one body region or with one population into other populations and examples. So we have to consider this as we're applying our techniques. So the way that I've grouped the thought process for us today is to look at the different indications we have for our stretching and then analyzing what does the current research say. And it continues to support that if we're improving range of motion, function, and flexibility, that yes, stretching can have a positive impact in those aspects. You may have reasons you choose one over the other, but overall, yes, it can be beneficial. The research also tends to agree that stretching is not going to help with delayed onset muscle soreness. It's not going to decrease that post-activity soreness that patients have. That's no longer what we're seeing. And we still have a question mark as to stretching's role in minimizing injury and improving performance. For those two, it really comes down to what type of stretch you're utilizing and when during your rehab. We're going to look at each of these considerations and analyze which type of stretching do you think is best to, or does the research agree is best to tackle those for your patient. As I mentioned, the research is very variable that's out there, so I did not go into it with a preconceived notion. I will bring up the positives and negatives of what I found so that you can apply it to your population. And first, when we're looking at stretching, just to increase range of motion. So you have a patient maybe who has undergone a total knee replacement and you're working on increased range of motion. Or they have a functional decline and we're trying to improve range of motion for improved transferability and gait. Typically, when we're looking at just increasing that joint excursion, we are finding that static stretching, where we take the joint to the end range of motion and hold our stretch there, is still beneficial. And the parameters that the research continues to support is a recommendation of a 10 to 30 second hold with 2 to 4 repetitions. It's nice to see that some things tend to stay the same. And it does find it beneficial that for these patients, if you are holding stretches for greater than 60 seconds, going up to 90 seconds, they found that it actually becomes detrimental, that you're not making any additional gains for those patients. So holding that 10 to 30 for 2 to 4 reps does seem to be where we are falling with our static stretching. There's also agreement that if we continue to stretch a patient, we will continue to see gains and we can even maintain the range of motion that the patient has. When we stop our stretching over several weeks, it seems like around the 4-week mark of time, they will start to lose those gains that were previously made. So there's definitely agreement that all those viscoelastic changes that we elicit can be maintained with continued stretching, but if we stop, we are going to lose those benefits that we had. When we look at our older population, the recommendation changes slightly. And what they are cautious to remind us is that as we age, our muscle integrity changes, that yes, there tends to be atrophy. Also, there is a decreased elasticity of the tissues. The connective tissue tends to become a little bit more fibrous in our older individuals. So I said, well, what's considered older? Am I there yet? How close am I to it? So the finding is that 65 and up is where the cutoff tends to be for saying middle-aged versus older adult in the research. Now we know that many individuals, and I live here in Florida, that their activity level far exceeds mine and they're older than I am, but that doesn't negate the fact that structurally their tissues are different. So we bear that in mind when we're employing our techniques. Low intensity stretching is important. Low intensity, meaning that you are taking them just to the point of discomfort, not the point of pain. That as you are applying the stretch, your rate is important. And I think this is important to consider as we look at the distal extremities. So the wrists, if we're stretching, the calves when we're stretching. As clinicians coming in, we want to come in slow with the force of our stretch because these tissues are a little less elastic. They are going to take a little more time to respond. So we don't want the initial force of our stretch to be too aggressive because we run the risk of some micro tears in the tissue that is slower to heal in our older individuals. Also, static stretching tends to be a better choice because there's less risk of that muscle spindle firing and creating that ballistic stretching with micro tears. So you just want to be slow in your rate and educate your patient not to perform that ballistic stretching. And the hold time does need to be increased. That older individuals' tissues need a little bit more time to respond for the stretching in order to get carryover of the effects. One particular study looked at performing straight leg raise stretching in individuals between 75 and 90 years old. They had a 62 participant cohort, which I thought was great to find 75 to 90-year-olds, 62 of them to participate in 5 times a week stretching program for 6 weeks, where they performed their straight leg raise stretch with 15, 30, or 60-second holds. And they performed 4 repetitions, and they put about a 10-second rest in between each. So straight leg raise stretch, holding it for varying seconds, relax for 10, go into their next stretch, and they did 4 repetitions. So sticking with our typical guidelines. What they found over time is that the 60-second hold yielded the greatest change in degrees for these patients, that they had a 2.4 degree increase in range of motion with the 60-second hold, which is significantly higher than for the shorter hold times. And then after they ceased the stretching, they followed these patients for 4 weeks out. And they found that they had a greater maintenance of the range of motion with the 60-second hold, that they still had retained a 5-degree increase, whereas the lower hold times really barely held a degree. So definitely with your older population, bear in mind that you want to have a longer hold time. Where I tend to educate my patients on this is when they're returning to wellness and activity, if they're going to classes at their local gym. I'll go to spin class, and then at the end of spin class, the instructor will take everyone through their stretching, which is great. I count, the average hold times are maybe 10 seconds, which for your middle-aged and average population is on the low end of what's beneficial. If you're older patient, it's after they warm their body up, best time to stretch. They're only holding for 10 seconds. That's a fraction of the time that the research says they need to hold to really get the benefit. Tie that in with whatever region they have pathology of. Those tissues we know need more precise stretching. So they may not be getting any benefit out of those 10-second stretches. So you might need to educate them that, yes, it's well and good that the class is progressing with their stretching, but for you, you need to be holding your stretches for this long. And maybe you need to step off to the side and do your stretching on your own afterwards. So be aware of that they need to be specific for themselves to have the most benefit. Our younger and middle-aged population, it brings the question as, yes, the hold time can be that 10 to 30 seconds to be beneficial. Frequency becomes a question also. How often should we have our patients stretch? Particularly with home programs, we want to make sure it's something that is attainable for them, that they're actually going to follow through and execute. If we're seeing the patient Monday, Wednesday, Friday, on Tuesday, Thursday, they still need to be stretching in order for overall gains to be employed. Do they need to also be stretching every day? One study looked at this and said, well, what is the difference in frequency? Does it alter the outcomes? And looking at a significant cohort study, they had over 50 participants. Again, looking at hamstring stretching, they were performing 30-second holds of the hamstring stretching, and these were middle-aged individuals and young adults, so 18 to 46-year-olds. I made sure when I read the study that they did take the stretch to the point of it just being uncomfortable, so fitting with the parameters that we're talking about. And they found out that over a 5-week period of this stretching, that whether you stretch once a day every day, twice a day every day, or you spread it out to 3 times a week, twice a day, the gains were equivalent. It agreed that if you only stretched once a day, 3 times a week, that's not enough. But I thought this was interesting to bring up because you can gauge your patients to see if it's that individual where maybe they work and you know what, they have kids at home. They are not going to be able to stretch every morning and every night and follow through with that. The research seems to be saying if you took that same patient and said, you know what, every other day, just stretch morning and night, that'll work. Or just do it once a day, every day. That we can have some variability here, and this is where our relationship building with our patient comes into play, to talk to them and see, well, what fits their life that they will be able to have follow through, so that we can have gains between their home program and their therapy, that there's opportunities here. I found another study that looked at kids between 10 and 13 years old, and in this they compared the different types of stretching, if they performed static stretching versus a PNF type of stretch, and they found, same thing for those individuals, that looking at frequency of stretching, that as long as the stretching was being performed appropriately and consistently, either spread out or every day, that there were equivalent gains. So something you can consider in negotiating with your patient their home exercise program. Our athletes, we know, are participating in their sport often every day for long periods of time. And the question becomes not only the type of stretching you do, but when to perform that stretching. Where in the sequence of their warm-up, participation, and post-sport should they be performing their particular stretching? And this is very interesting to consider. It's very important to note that when we perform the stretch has an impact on our outcomes, because it's not only going to influence muscle length, it's going to influence power for that muscle. So we're finding that if we post-exercise complete our static stretching, it has the most benefit because the muscle is warmed up. Within 5 to minutes post-exercise, we are able to stretch that muscle that has been heated, so we're able to have better gains. So often for your athletes, the practice should be, or individual returning to recreational sport activity, they should be stretching after their participation in the activity with their static stretching, because that's going to give them better gains. What we're finding is that our window that tends to occur in terms of when our stretching is most beneficial, that the gains, if someone does a static passive stretch, those initial significant gains, within 15 minutes, we start to see that creep setting in. So be aware that timing of your stretch, the better option for patients is after they're going to perform their sport or their activity participation. The duration of the gains, how long this is going to allow for increased muscle length. We tend to see that about 6 to 25 minutes, some of the research says within 15 minutes, that muscle length tends to return back to its baseline. So what does that mean? If you're timing your goniometry measurements for progress of the patient, that we really need to be measuring those gains right after our stretching to see, what is the maximum muscle length that we can achieve. Also consider, if you are an assistant working with the PT or the OT, kind of know their routine for measuring, because if you're seeing variables in your goniometric measurements, it might be related to this creep effect that we do tend to see the greatest gains right after stretching, but maybe if you're stretching at the end of the session after your other interventions, you may have a little loss in the range of motion. So be aware of that in your sequencing of your sessions. Considering individuals who need excessive range of motion for their performance of their different activities, know that larger muscle groups in general are going to need a greater hold time or greater repetitions in order to have increased range of motion gains. So your quadriceps, your hamstrings, maybe your gastroc that have more a cross-sectional area, you're going to want to be at the higher end of the hold times, and you're going to want to be at the higher end of your repetitions, as opposed to your smaller muscle groups, maybe your wrist flexors or extensors, or if you're an OT hand therapist, your smaller intrinsic muscles of the hands, they may not need as much of a hold time in order to make their gains. There's also been some research looking at different types of stretching. We've really been talking about static stretching up to this point, but if you consider patients who have, they looked at a group of patients who had low back pain, who had tight hip flexors, tight iliopsoas, they compared a 6-week program for those individuals of having them do a dynamic stretch where they did progressive lunges, stepping lunges, versus being prone and doing leg lifts to stretch that iliopsoas. And they found for those patients that there were equivalent range of motion gains. When developing our home exercise programs, think about what level of activity your patient is going back to, and you might be able to use an active or a dynamic stretch that is also working on strength, balance, control, and you're maximizing the benefit of your time with your range of motion gains and your return to function for those patients. Or, think about the position the patient needs to be in. If it's that back patient, maybe having them do the prone active stretching leg lift to stretch the iliopsoas, and then they're going into their higher level back exercises that are already in prone, or your McKenzie program, whatever you're up to with them. So you're minimizing position changes. It's at a time of day before they get up in the morning, so it's most beneficial for their pathology. So you might think about incorporating these different types of stretching into your program to maximize your overall benefits. PNF stretching can be utilized for range of motion gain. Some of the research says that PNF stretching, where we have that isometric hold, can be just as beneficial for static stretching. They're seeing that in our rehab populations that this type of stretching can be beneficial for patients to make significant gains, that active contraction before the stretch allows for more range of motion improvement. If we consider managing contractures, that is a little different than range of motion restriction that we've spoken of up to this point. We've been looking at decreased range of motion as a muscle flexibility issue. If a patient presents with a contracture, contracture is looking at all of the structures around the joint. So contracture is when a patient has decreased joint excursion, and it's determined that the different ligaments, that the joint capsule, those other non-contractile periarticular structures are what have tightened down, not allowing for the joint excursion. that it's those other structures that are contributing to the decreased range of motion. We see this happen when a patient has functional decline. They haven't actively been moving through a range of motion, so these joint structures tighten down. With our neurologic populations, we may see this also, or someone who's been immobilized for a period of time. If we are just performing stretching techniques the way that we've been discussing up to this point, it's not likely to be effective in managing contractures because we're taking the end point of our stretch to the point of the muscle lengthening. So we're going to the point where we're I can use my fingers here, where if you're performing a finger extension for the patient, you're extending that joint to the point where your tendons of your finger flexors have become elongated as much as they can, and that's what's stopping your motion. That's not necessarily bringing you to the end point where you're really stressing that ligament and capsule of the joint. You might need other interventions, modalities, mobilizations to really get in and target those periarticular joint structures in order to regain their length and elasticity. So stretching alone, while patients who have contractures, we may need to do stretching, that intervention by itself is not going to really get down to those structures around the joint in order to fully stretch it. Where they are seeing some benefits from the research is in prevention of contractures as opposed to managing them once they have occurred. In looking at individuals who had a hemiplegic shoulder, they were performing positioning programs for abduction in order to limit the rate of contracture development of the shoulder. And they found that while positioning programs can be beneficial to decrease the development of contractures, on the flip side, in those patients, in some cases, it increases the rate of shoulder pain, hemiplegic shoulder pain. So it is kind of a balancing act there where you need to continually reassess your patient. But if it's contractures you're looking, maybe stretching can help manage it. But once they develop, you're going to need other more specific interventions to actually treat contracture. Spasticity with our neurologic population is another question that comes up as to whether or not stretching as an intervention can manage spasticity. To review, spasticity is different than muscle spasm. Muscle spasm is a protective reaction. So let's say a patient has a whiplash injury, those erector spinae and other structures in the cervical spine are going to contract to hold those regions steady to limit future involvement or potential additional injury to the individual. That's going to be a muscle spasm. What happens with spasticity is very different. Spasticity is when we have a neurological insult and our higher cortical centers are not inhibiting that reflex arc. So in the upper extremity, let's say it's the fingers and the hands, our wrist flexors are firing with that reflex arc, and our higher cortical centers are not sending that signal down to say shut off. So we have spasticity. It's a neurologic condition. When we look at stretching, just to take that and hold it at its end range of motion, that technique is not going to be the best choice to inhibit the spasticity. It's not really tapping into the central nervous system in a way that's most beneficial to decrease spasticity. There was a huge Cochrane review, which is where they take all the different research studies that are out there, and they found about 1,400 participants from different studies who had spasticity, and they performed manual passive stretching on those patients in all the different studies. And it was concluded when they looked at all of them that it really wasn't beneficial as your technique to manage spasticity. You need other specific interventions to target the neurologic system for those patients. Now, that's not considering serial casting or prolonged stretching. We're just saying manual passive stretching is not going to necessarily decrease that much. If we look at some other responses that our muscles may have to our stretching, we need to consider the sequencing of our interventions in our session, because when we stretch a muscle and we elongate those muscle fibers, we are going to alter the length-tension relationship. So if you picture that actin and myosin overlapping, remember we said we're stretching it to its limits to have the sarcomerogenesis and the other benefits from the satellite cells. Well, we've altered the length-tension relationship at this time. So physiologically, because we've spread those cross bridges apart, they're going to be less effective in generating their force. And what the research has found, that about 15 minutes following, static stretching, that those muscles have a decreased ability to generate their force. This means if you ask that muscle to contract immediately after a static stretch, it's going to have less power and less ability to be effective in generating its force. This is important to note in the sequencing of your sessions. If you perform your manual passive stretching of your patients, and let's say it's of the quadriceps, so you stretch those quadriceps, and now you go to do your standing activities with the patient, to do stair negotiation, or you are working with them on their ADLs and you're going to take them into the shower now to balance on uneven surfaces where they may have to use hip and knee strategies to balance. If it's within 15 minutes of performing your static stretching, you may have placed that muscle at a disadvantage to develop its force and control, so the performance of those activities may be impaired. So during your sessions, think about your sequencing so that if there is a decrease in power and strength that the patient can develop, that you have some time between your static stretching and your requesting of the demand on that muscle. Maybe you sequence in between there your mat exercises or other interventions where if the patient does have decreased power and control, they're not at a safety risk for falling, if that does come into play. Or just guard them more closely to be aware. A better alternative that some of the studies say is that we use our dynamic stretching for patients. Now, in our lower level patients, that's probably not an option, but for our athletes, you want to consider that we might use our dynamic stretching instead of static stretching so that we negate the possibility of decreasing their power when they really need it. When we look at just the mechanical factors of the joint and, well, why does a muscle have decreased ability to generate power right after that static stretch, it goes back to the fact that that musculotendinous unit, once we have stretched it, its ability to generate its force, transmit that through the tendon to the bone, is going to be limited. So it's going to develop decreased peak force, they're finding, a slower rate of contraction, versus the dynamic stretching where the patient has done their knee kicks or their arm swings, where they're taking themselves through the range of motion, incorporating active muscle contraction with relaxation and range of motion gains. They tend to find that this is priming the muscle better for its contraction, that we don't see a decrease in force of the muscles. So this might be your better choice for particularly return to sport or activity, to do dynamic stretching before their activity performance. Another aspect that they found, it's very interesting, that dynamic stretching, when they look at the firing rate of the motor units, they found that we have more synchronized muscle spindle firing after dynamic stretching versus the static. So when we try to voluntarily activate our motor units after stretching, when we performed just that static stretching, that they had decreased axon potential formation, that they were not synchronized contractions, so that limited the power that the muscle was able to generate. So this becomes a dilemma, right? We said that static stretching is really beneficial at making range of motion gains. But dynamic stretching is better so that we don't compromise muscle performance. So how do you decide which to do? It might be a combination. Let's say your patient is an older individual who maybe they're participating in a recreational softball league, and you are working with them. Well, they need to crouch down. So maybe they need some static stretching of their quads so that they have the range of motion before they go into that squat position. Or it's your younger hockey player or lacrosse player that needs that range of motion. But in their upper extremities, where they need the power and the strength and they need to be able to control their upper extremities, maybe you're giving them a dynamic stretch so they don't injure their rotator cuff and overstress that during the catching or the throwing, whatever the upper extremity movement is, because that rotator cuff is going to be more sensitive to increased exertion, creating inflammation and additional injury. So we might try to mix up for different regions of the body the type of stretching that we're doing for the patient. Generally speaking, it'll be better if they need that static stretching to do it at the end afterwards. But if because of their pathology, they need some isolated stretching or they need a specific range of motion of a particular joint before participation, you might do static stretching for that joint and then just do some dynamic stretching afterwards, because that'll help prime the nervous system better to then be able to react and participate for the activity. When we look at comparing our PNF stretching to our static stretching, we're considering the fact that for our patients, that PNF stretching tends to be a better option for patients who have more of a sedentary lifestyle. So maybe the patients that we're seeing in rehab where there's deconditioning or decreased mobility, and now they've had a fracture or a joint replacement, or they're just our patients in the skilled settings, that PNF tends to be beneficial for those patients. And having that initial isometric contraction before the stretch allows that muscle to more fully relax. So we have a better ability to generate the stretch, knowing that muscle is more turned off, so to speak. It's more inhibited. So we have less of a likelihood of traumatizing that particular muscle. Might be one way of thinking. On the other side, you do want to consider the fact we said that with our patients who are very weak, we don't necessarily want to use up their muscle power and energy with PNF stretching that they may need for functional task performance. So it's always going to be a balance. And you might try both and then see in your patient how they respond. You might consider with your PNF stretching, if it is a population where you're going to decide to use autogenic versus reciprocal. So let's say it's that upper extremity patient where maybe you're working on grasping and reaching activities with them. If you are trying to gain range of motion, let's say they had a flexor tendon repair in their hand. So you're trying to gain range of motion of finger extension, and you want to use a PNF type of stretch. If you know your functional task is going to require them to do grasping with their flexors, well, instead of doing autogenic stretching, do reciprocal stretching. Take them out to their end range, isometrically contract the extensors, and then gain your range of motion. So maybe you can get the benefit of that active stretching, but you're not engaging the muscle and potentially weakening the ability of it to generate its force when you go into your functional task. Lots of different ways you'll be able to consider to apply these different ideas. Also consider when you look at muscle strength after stretching, the timing of our assessments. Patients, how often do you see them in the gym, or individuals in general working out? They go to the gym, they do their bench pressing, and then after their one set, they get off the machine, they put their arm up, and they do their stretching of the pecs. And then what do? They sit right back down, they go back to their repetitions. We just discussed the fact that after we statically stretch a muscle, its length-tension relationship has changed. Its ability to generate force has changed. It's inhibited, essentially. So this patient sits back now like this, stressing the rotator cuff, which is why he was in therapy in the first place. And now they're decreased ability to generate force with those pecs because they just stretched, and that will now, they go to push, can't generate the force with the pecs, rotator cuff becomes stressed, exacerbating the pathology. It's important to look at our sequencing and our educating of our patients for return to activity so they sequence it appropriately. This individual should not be doing static stretching in between repetitions when they need to generate power and force. That should wait till the end of the intervention. If this individual feels the need to do some stretching in between, they should really do a dynamic type of stretch in that case. As clinicians, think about your manual muscle testing. If you perform your stretching intervention, then you measure your goniometry, perfect, and you go right into your manual muscle testing, that muscle has a decreased ability to generate its force, so you may not have a very accurate manual muscle test grade. Bear that in mind in your sequencing of your assessments. Muscle fatigue is the next aspect to consider. When we look at muscles, considering the fact that they need to have endurance for participation in function, we can look at the number of repetitions that a muscle can perform to give us a sense of endurance. We can look at the power that it can sustain. And then we can also look at exertion scales, such as the Borg scale, where a patient's going to rate how hard they're working. What the research has found is static stretching really doesn't tend to change the amount of force or power that can be generated related to fatigue. What they tend to see is that patients can compensate. That if the muscle is fatiguing after stretching has occurred, the patient will still be able to perform their activity, but if you do a Borg scale to rate it, they'll indicate that they had to work harder in order to perform that same task. That they're at that the muscle is actually fatiguing even though they're still able to do their activity, so it might take more concentration from them. It might take more contractions to stabilize. So if someone's stretching and then they're going into activity participation, know that immediately after that stretching, that's when they're going to be more likely to substitute and compensate. So again, in our sequencing of rehab for our patients, we might stretch, go into maybe open chain exercises, knowing that we can modify it and look at quality and quantity of movement, and then go into closed chain after we've gotten the benefits from our stretch, but any possible negative implications on endurance and strength have been mitigated. so that we can meet with better success and less likelihood of injury for the individual. When we consider muscle pain, the population that I want you to consider stretching relative to might be your chronic pain patients. Those individuals who have chronic conditions, where other interventions have not been successful. If you haven't considered utilizing stretching, it might be an opportunity for you to tap in and break the pain cycle and improve function for these patients. There was a couple of different studies that looked at this. One took individuals who had chronic neck pain, and they were assessing the severity of their trigger point pain. What they analyzed were comparing groups of individuals who underwent a stretching program with those who underwent a strengthening program in manual therapy. So comparing stretching to strengthening and manual therapy for individuals with chronic neck pain, when they assessed the trigger point sensitivity, they found that those who participating in the specific stretching program had greater relief of their trigger points, indicating that stretching may have more of a benefit in trying to break that pain cycle, because it not only can decrease the pain, but it can also help restore muscle length, and then they have improved mobility, postural alignment, and the sequela in that respect being positive. Another interesting study I found looking individuals with chronic pain was in Korea. And Korea, I've learned, they have a huge mass transit system. So back in 2011, they studied 95,000 of their individuals who have back pain. And they found that 82% of individuals who worked in the transit system there had chronic pain. And that's because when they're driving these large buses and mass transit type of equipment, there's a lot of road vibration, and vibration has a significant impact on our bodies, leading to musculoskeletal trauma, compensations, and increased pain. So these individuals were presenting with a lot of low back pain. So they took them and they had the individuals progress through a supervised physical therapy program with very specific stretching. They were looking at holding the stretches with the same parameters that we're talking about, 25-second stretches, 3 times each, 3 times a week, over 4 weeks. And they found that these individuals had a significant decrease in their reports of their back pain. And this is important to think about with our patients who have chronic pain. Not only do we want to manage the pain from a musculoskeletal perspective, but think about it also from a cognitive and a psychological aspect for the individual. Because when someone's in pain, they're more distracted, their concentration is impaired, their judgment is impaired, so they're at greater risk for work-related injuries, as well as maybe not having the spontaneous reactions for fall recovery. So again, finding another way to tap into chronic pain through stretching might be something to consider if you're working with that population. It seems to have a benefit. And kind of linking this psychological with physical component, there's been some research considering yoga for this population. So looking at that active type of stretching technique, they were seeing that there are some positive benefits in individuals who have back pain. In considering those who had an intervention where they either just received a book about self-awareness and pain management as their intervention strategy, compared to those who underwent a yoga series, that the individuals who utilized the yoga treatment, when they studied the medication use of the patients, they found that individuals who participated in yoga had a 40% decrease in the amount of medication use that they reported. And this is important because patients that have chronic pain, if medication is the primary method of management, if it truly is just a pain management, not tackling the cause or the etiology of the pain, that medication over time places significant stress on their other body systems to metabolize it. It's expense, it's time, and it doesn't empower the patient. If stretching, particularly yoga, is tapping into the psychological piece to empower the patient. That can improve their outcomes. And now some of the research is saying that because it's increasing flexibility through the stretching, that somehow that is allowing for greater pain management also. So we're seeing decrease in medication use for those patients. So an interesting population to consider that you might want to add stretching into your plan of care for. Muscle soreness, let's look post-activity now. Muscle soreness, delayed onset, muscle soreness is something that has evolved over my career. And those of you that have been in the profession for a while, you probably have seen this happen. Way back when, in the 1960s, that was before I started practicing much, but it lasted for a long time. The theory that after you exercise, that soreness and discomfort that's perceived in the muscle, the thought was it was the muscle spasming up post-activity in order to protect the region, that muscle spasm creates pressure on the blood vessels going through the region. So we have decreased oxygen and nutrients coming in, decreased pumping out of the metabolites from the muscle contraction. And the idea was, well, if we could relax that spasm through stretching, then muscle soreness would decrease. Well, that was the traditional belief that lasted for a very long time, and I can tell you that's what I learned back in school. However, continued research changed, and they found that's not what's really happening. So the shift in somewhere in the 80s went to the fact that delayed onset muscle soreness is based on lactic acid buildup. And some of you may have heard that lactic acid builds up as a byproduct of the energy production for muscle activity. And because that lactic acid is present, it is a chemical irritant, and that causes the pain and discomfort that someone feels after activity. This was discredited in the 2000s. So depending on when you went to school, we're getting close to your theory. This was discredited, that they actually said, okay, well, let's look at the lactic acid. Let's study it in the tissues. And it's confirmed that, yes, lactic acid levels rise in muscles after activity. However, within 30 to 60 minutes post-exercise, those levels are coming back down. So they can't possibly be accounting for the fact that over 48 hours after activity, we see the maximum muscle soreness, and then by 96 hours, it decreases and we're back to our baseline. Lactic acid is not our culprit. Our current theory that the research is supporting is delayed onset muscle soreness. If you think when you see it, even in yourself, not just your patients, it is going to happen anytime there is increased activity, when that muscle is pushed to its point to be exerted. That it is a normal physiologic response regardless of fitness level. It may take a different amount of exercise to bring someone to the point of soreness, but it's pushing that muscle towards its limits. So what they're found is, as they looked at the muscle fiber level, they found that when a patient is participating more in eccentrics, plyometrics, resistance training, that we see greater onset muscle soreness because it's a little bit of an inflammatory process. That when we look at our individual myofibril and muscles, we're seeing that the sarcomere is damaged a little bit from the force of the activity, which is what we want in order to stimulate it to be rebuilt. That membrane around the muscle fiber is becoming damaged and irritated. So there's a sequela of chemical events in order to stimulate healing of that muscle fiber. That those chemical irritants are going to irritate the adjacent nerves, create a little swelling and microinflammation in that muscle, and that's the pain that's perceived. And it follows a cycle of climaxing at 48 and dissipating around our 96-hour mark because healing has occurred. The muscle has responded appropriately. So this is what's happening with delayed onset muscle soreness. If you believe that current theory that the research is supporting, think about what we said stretching accomplishes. It really is not doing anything to intervene in that process. We are not changing the level of irritation. We are not pumping out any of the chemical irritants with stretching. It really is not eliciting any effects from the stretch that will help limit the delayed onset muscle soreness. So that's not your intervention of choice if your patient has muscle soreness. It's more likely that if your patient has muscle soreness, what you need to look at is your pre-activity participation. If you feel that muscle soreness is disproportionate to the activity, or it's lasting longer than it should in this expected cycle, then it's of concern. But for the most part, delayed onset muscle soreness, it is a normal response of the tissues to activity. You don't need stretching to relieve it because it doesn't match up. And the research is supporting that. Another Cochrane review, they took many different studies. They actually found 12 different studies that looked at delayed onset muscle soreness. And they ended up with about 2,000 patients that were analyzed in all these different studies. They only looked at those that had high consistency, good study technique. And it was in 2007, then in 2011, they repeated this whole process of gathering all the research. And they used this translation of a 100-point scale to look at patients who stretched before they exercised, stretched after they exercised, and then stretched before and after. And on a 100-point scale, they had each group rate, well, they attached a rating of, well, what was the change in the person's pain from stretching? Did it really impact the delayed onset muscle soreness? And what they found, you can see, is not statistically significant. On a 100-point scale, if you stretched before and after you exercised, it only had a 4-point decrease in your delayed onset muscle soreness. So this reaffirmed the idea that it's not your intervention of choice in order to impact that condition. Where we can make a difference is related to athletic injuries. We need to consider our stretching intervention in this case. It's important to recognize that a lot of times stretching is utilized in order to prepare the muscles for participation to help decrease the risk of injury. Everything we've spoken of it up to this point reaffirms, well, it's the type of stretching and when you do the stretching that really has your greatest benefit. Traditionally, the view was stretch before so that you're primed. Now we know that's not necessarily the best choice. The research, while it's all not 100% consistent, it does agree that they cannot endorse or encourage stretching before sport participation as a way to decrease the risk of injury. The concern is actually the opposite. The research is showing that because stretching can decrease the ability to develop power, that it may influence muscle fatigue, that it might actually shut down that muscle firing very short period of time after stretching, it could place the patient at a greater risk of injury from that stretching beforehand, particularly if it's a static type of stretch. So it's important to know that because we statically stretch that muscle, that it decreases the ability of it to generate force. Now that muscle is going to be unable to generate power to stabilize the joint or execute the task. That may actually contribute to an increase in athletic injury. So static stretching probably isn't your best choice. Dynamic stretching is going to prime that system so then it can participate for that patient. So dynamic stretching may be your transition for your patient as they're returning to their activity, or their static stretching is performed in the morning, at night, or after their participation to be most beneficial to avoid the risk of injury. When we consider the fact that many sports require individuals to have excessive range of motion, consider your dancers. Your twirlers, your gymnasts, even your wrestlers that get into different positions. They may need greater range of motion, so over time with their stretching, they're habituating that muscle spindle to accept a new endpoint as the appropriate range for that joint. And that's great when they are in the sport, when they coordinate that with having good strength of the muscle to stabilize at that new range. But consider that patient when they stop participating, or that individual, an athlete, when they stop participating in that sport, where now their muscle spindle is habituated to allow this excessive plantar flexion range of motion because they're a ballerina. And their strength is great of all of the anterior tib, posterior tib, peroneals. All those muscles are so strong so they can control themselves in those excessive ranges. Now they stop dancing. That patient's going to be at a greater risk of an ankle sprain because as those muscles atrophy, the muscle spindle still accepts a greater range of motion, so it's not going to kick in with that protective reaction, increasing their potential risk of injury. So consider that habituated response, that when someone is, leaving a sport, that they need to build up more strength in order to limit the risk of injury. So be aware of that for your patients. When we look at performance, when an individual is participating in their particular sport, we've again made the case that they have shown decrease in the peak force that can be generated immediately after a static stretch. This has been correlated to decreased ability to generate power during plyometric movements, jumping, quick changes of direction. So we want to avoid that static stretching when we're going to be asking that muscle to be put on a demand. Also think about your patients as they're rehabbing from a particular injury. If you statically stretch them first and you're establishing a new endpoint, and then you're requesting that muscle to perform its task, you're going to have decreased joint stability initially because it's going to be less efficient in generating its force of contraction. That tissue is more compliant, the muscular tendinous unit, so it can't pull as well on the bone to generate its force. It also can't absorb energy as well. So going right into an eccentric type of activity following static stretching is not a good choice because the muscle is not going to be as able to generate that force and control and absorb the shock of a movement. So be aware of your sequencing in that respect, because we're going to see that there's decreased ability of the muscle to develop that explosive type of power and force. So your better choice for your patient when they need to do quick changes of direction and different types of activity is to select more of an active or dynamic stretch before their performance, as opposed to a static type of stretching. Running is something that has been considered in specific relation to our stretching. If we consider the hamstring stretch of patients before they run, we need to have hamstring length in order to allow excursion through the swing phase for the runner. That when we go through our athletic performance for the patient, that let's say this individual is going to go run on the treadmill, so they perform their static stretching of their hamstrings, and one particular study analyzed this and said, okay, great. When we measure that patient's sit and reach, so that is looking at hamstring length where they lean forward, yes, they had an increased range of motion, which we agree with. Static stretching is going to accomplish that. They also found when they measured the stride length of that patient, so looking at the heel contact for the patient and how long each swing phase was, they saw that they had a greater swing phase, which makes sense. There's more muscle length, so that, heel strike goes out a little bit further. What was interesting that they found is that the biceps femoris EMG activity increased. So the biceps femoris is one of our hamstring muscles, two muscle bellies to it. They found that it increased its firing. So that kind of goes opposite everything we've been saying up to this point. You statically stretch, but we're supposed to be losing power. We're supposed to be fatiguing the muscle out more. Why would the EMG firing increase after the static stretching? What the study concluded, which I just find really interesting, is that I'm going to use my finger here as my hamstrings. But if we look at the patient, they had greater hamstring length. So they could get more knee extension during the swing phase in order to contact the ground. But as that knee is extending, you need to have eccentric control of your hamstrings to make it a controlled knee extension. So that hamstring is firing to slowly let that knee extend to hit the ground. Otherwise, it'd just be a pendulum swinging. So when they looked at these runners, they found that their overall running time was the same. But if they look at the start and the perceived exertion, they all said that at the beginning of the run, I felt like I was working harder. And the EMG agreed with this, saying that that hamstring, that biceps femoris firing, had to work harder to decelerate the knee. It had to recruit more muscle fibers to control that knee early on in the run than it did later. Reason being, if the hamstring was inhibited from generating its power early on, it had to recruit more motor units to accomplish the same task. So it reaffirms everything that we've been talking about. And then the individual perceived that as, you know what, I had to work harder in the beginning of the run, and I ran slower in my first mile or two than I did in my later miles. What does this mean for our patients? It reaffirms what you were saying, which I thought was fascinating, and it makes it functional. But it also shows us that when we educate our patients, particularly those who, are going to go out and make their own decisions in terms of their activity performance or recreational sport participation, that the more information we arm them with, the better decisions they can make. Because if we educate this patient that, static stretching is not the best choice, what you should have been doing maybe were some leg kicks, do a dynamic, you may see an overall improvement in your running time, or you wouldn't have to work as hard at that task. Another population that I looked at, because I'm here in Florida, what does almost everyone do for their recreational activity is participate in golf. And golf is not an easy sport if you have ever tried it. I tried it once, and I blamed my lax musculotendinous unit for my horrific performance. So if you ever need an out, I would go with that. They looked at a bunch of golfers, and what they found is that that more compliant musculotendinous unit did not allow for as much control of motion, and it led to decreased coordination and accuracy in the golf swing. So they found that the individuals who participated in static stretching of the upper extremities versus the swinging of the clubs that you may see, or more of a dynamic type of stretching, that those static stretch had poor game performance. That when they tried to control the club to make contact with the ball, that minute control for accuracy and speed and how much force they were applying, they weren't having as much feedback to adjust that appropriately, and then they just couldn't control the execution as well. So that decrease in force production, but also we said that the static stretching is not as beneficial as the dynamic in priming the musculoskeletal system for synchronized muscle contractions, that this was reaffirming the fact that it was more beneficial to go with that dynamic stretching. So dynamic stretching should really be sport specific so that it primes the right muscles in a way that they're going to request them to be utilized for the activity participation. So I still blame my poor golf on my stretching, even mini golf. I'll whip out a couple of stretches first, so when I lose, I have an excuse. So that's something to consider. If we want to enhance performance, let's kind of flip this around and use it the other way. If we are trying to design our routines for a patient to enhance their muscle performance, and now again, you can take this to the point where they're actually returning to a recreational activity or sport participation, or at a lower level for some of our patients, for their specific activities, we need to consider that static stretching may not be the best position or the best activity to utilize to prime them, even if their functional task is just gait and transfers and level surfaces. Considering specific sport performance, looking at individuals who played tennis, that requires a lot of quick changes of direction, a lot of eccentric control and power and force for individuals. They looked at a squat jump, which is where you're already in a squat position and then you power up, versus the counter movement jump. That's more your plyometric. So where you go, you start standing, you squat into an eccentric, and then you explosively power up to squat back down. So there are two different types of squats. And what they considered is, let's do passive stretching on the patient, active stretching, and then dynamic. And what they found in looking at all these different numbers here, the takeaway is that the dynamic stretching did allow the patient to have a better plyometric type of jump, where they went eccentric, concentric, and then landing for an eccentric, that it reinforced that priming the musculoskeletal system for that explosive power. So think about basketball, volleyball, quick changes of direction where we need force. That dynamic stretching is a good choice for those patients in those particular studies to allow for more power and recruitment compared to that static stretching. Mentions the static stretching that it may be necessary. If you're a patient, let's say they had a Banker procedure completed on their shoulder because they had a tear, or they had a slap lesion, and they're a volleyball player. Well, they need that range of motion if they're a hitter to be in the front. They need, if they're a blocker, to be able to get those arms up and be ready for it. So part of their rehab, yes, is going to be specific stretching, because we need to maintain that range of motion. And we know that even when they're in the chronic phase of healing, where those collagen fibers are laying down and we're developing our exercise and stretching programs so that the forces exerted on them allow for the proper alignment of the collagen, all those basics that we know, we're doing some very specific static stretching for all the effects that we said. Stimulate the satellite cell production, etc. We need that. But that patient may not be performing that static stretch of their upper extremity while they're out in that 30-second timeout and then have to go right in and generate a hit. Because what's going to happen? If that rotator cuff can't stabilize that shoulder and they're coming up for that hit, and they have the contact of the ball, now they need a little eccentric contraction followed by a concentric. If they just statically stretch, they're not going to generate that power, and they're at a risk of re-injury. So maybe teach them, if you're feeling you're getting a little stiff, a little inflammation setting in there, give them a dynamic stretch to use then, or some kind of active stretch so they can go back into their play. Then later on, after the game is over, then have them go into their good static stretching routine so that you are continuing to allow that tissue to heal and decreasing the risk of re-injury down the road, because you want to maintain its muscle length after the injury. So be aware of that if you use that static stretching, you need that, the research says, somewhere between 6 and 25 minutes before that muscle can truly be back to generating its power. So bear that in mind, that this timing really makes a difference. So the type of stretches that we utilize with our patient may change over the course of our rehab from them. That our patient who had a hip fracture, who had a total joint replacement, maybe they have, a Colles fracture, and it's their wrist that we're trying to regain range of motion. During rehab, we're probably utilizing static and PNF stretching for those patients, because that's what's most effective in making range of motion gains. Based on what job they're going back to. They may not even play a sport. Maybe they work in a manufacturing plant, and doing repetitive motions over the course of the day is requesting certain coordination and demand out of their body. Or balancing out on that construction site and moving those brick pavers all day. They need power and strength as they're recovering. As they go back to their either sport or work activity, then we might decide we need to incorporate different stretching so that they don't place themselves at a greater risk of injury down the road. Generally speaking, where this brings us to is that passive or static stretching is beneficial to increase flexibility, that it can be more effective in patients over the age of 65 if we hold that static stretch for closer to 60 seconds. That increased hold time is going to give greater benefits for our patient. And they're also finding in the research that over time, if you stop the stretching, that you will have loss of that range of motion if the patient isn't continuing to utilize that new range. So the research varied that, 4 to 6 weeks after stopping stretching, if you're not using that range of motion, you seem to start losing it. So it varies there. Something to consider if you're looking at follow-up for your patients, if you were employing something to do follow-up on programs for patient, somewhere around the 4 to 6 week mark might be the time you want to check in with them to make sure they are still continuing with their stretching program if that's what you utilize, because that's where you might start seeing the loss of your gains. Again, if they're not using that range of motion. The passive stretching, we're going to generally, if the person does some type of aerobic warm-up first, so let's say they're coming in the clinic and you are going to be stretching their lower extremity, maybe you have them on the bike first. Or if you're going to be stretching their shoulder and elbow, maybe they're on the UBE first. A little bit of a warm-up first for general fitness, and then go into your static stretching in your therapy session. Versus for our athletes, you're going to be utilizing the stretching as the cool down routine, or after discharge for a patient, after they have their return to wellness or return to function, or end of their work shift. After the muscles warmed up, that's when you're going to utilize that static stretching for the individual. Dynamic stretching, the research seems to say that it can help increase muscle performance. Some of the studies do say that it doesn't have an effect, but the concern is that it doesn't necessarily make your performance better. It doesn't inhibit the performance in the same way that static stretching would. That it has a greater opportunity to increase the muscle firing, increase the power and the strength. So dynamic stretching to be sport specific, you can do your warm-up, some type of aerobic warm-up, followed by dynamic stretching, and then you go into your sport-specific runs and drills, followed by your participation. PNF stretching, where that tends to be most effective, they feel that during rehab, your contract relax stretching is more effective, so that's your autogenic inhibition to utilize during rehab for our patients. The caveat to that is you have to decide if you want the patient to expend their isometric muscle endurance for your stretching technique. So if they're extremely weak, you may not want them using that muscle contraction that they need for your functional activity during your stretching technique. That might be why you would decide not to use it. They really didn't give any cutoff with that. Just a couple of studies mentioned that delayed onset muscle soreness or using a full maximum contraction can then, tire out that muscle. So you want to stay down maybe the 75% contraction. If we consider where the modalities fit in with our stretching techniques, sequencing during our session, that might be other interventions that you're incorporating during your time with the patient. We know that modalities aren't the only intervention that we utilize, but if we time them appropriately, that the modalities can be beneficial to increase the collagen extensibility. For example, if you're using heating or ultrasound in order to allow better realignment and reorganization of those fibers when we apply our stretch, and then kind of holding that. Some clinicians even say during the cooling. What we have to consider is our stretching window. And this is very interesting if you haven't heard of the stretching window before. And this comes from the research by Draper, who completed a series of studies back in the 90s. And I don't know how he had participants for this study, but it's fascinating. So he had different participants who allowed for a hypodermic probe to be inserted into their tissues to monitor the temperature. And the individuals received an intervention in order to increase the heating of their tissues. So ultrasound was applied to increase the tissue temperature, and they monitored the tissue temperature increase with the hypodermic needle to see how high the heat was achieved. Because what's important to note is that when we know from muscle physiology and responses of tissues that if we have a 1 degree increase in tissue temperature, we start to see a little increased metabolic rate in the cells. If we get to a 2 degree increase in tissue temperature, we're starting to see an increase in circulation, so that can help in pain reduction by sedating the nerve endings. It can help if there's a spasm with restoring the circulation to decrease the tissue hypoxia. But by the time we get to a 3 degree and above increase in tissue temperature, that's when we really start to see changes in the viscoelastic properties of the tissues. So vigorous heating is a greater than 3 degree tissue temperature rise, and that's when you can really marry the benefits of your heating modality with your stretching. That's when you have the best opportunity. So Draper said, well, how long do we have? Okay, you get this 3 or 5 degree tissue temperature rise. How long does that last for before it starts to dissipate? Because we need to get our stretch in that window when we're up 3 degrees and above. And what they found is that, within 3 minutes, the first 3 minutes after stretching is when the tissue stays above that 3 degrees to 5 degrees. So your stretching really should be combined while you're applying your heating modality. And if you can't do that, you need to stretch immediately after removal of your heating modality, because that's when you're going to have the most benefit from your stretching. That if you wait longer than that, the tissue temperature continues to decrease and you're not getting the most benefit. So think about your positioning when you're setting up for your modality. If you can position the patient so that gravity is assisting with the stretch while you're applying the heating modality, or place them in a position, let's say you're stretching the shoulder capsule for adhesive capsulitis. Well, rather than having the arm adducted and internally rotated at the side, besides the fact you're not exposing the whole joint capsule to do ultrasound, take them at their end range, abduction, external rotation, assuming you're not impinging, and ultrasound here so that you can be progressively stretching while you're applying your ultrasound. When you're done with the ultrasound, you have them in a position you could go right into your additional stretching to maximize your benefit. If you're ultrasounding that gastroc for your patient with, let's say, Achilles tendonitis, you have them prone. Put that gastroc on a stretch. It'll flatten out the tendon, so you'll treat more surface area with your ultrasound, but you're applying the stretch along with it, and then you have them in a position when you're done with your modality, you can continue with your stretching. That's really where the research says you have your best. Other studies looked at, okay, so modalities may have a benefit in that respect, but let's compare stretching to active warm-up to superficial heat to ultrasound. So we have all the different options here. And what they looked at is comparing the differences. And they found that at 6 weeks out, static stretching was the most beneficial for patients who had, I want to say these were plantar flexion contractures, or not contractures, sorry, decreased plantar flexion extensibility for the patients who had ankle pathology. And they had a cohort of almost 100 patients, so it was a long-standing, long cohort group. And what they found is that if you had, 6 weeks to treat the patient, that static stretching was beneficial. What was interesting is they found that if you had less time to treat the patient, that at the 2-week mark, the patients who received ultrasounds with their stretching had better gains at the 2-week mark. What does this mean? Consider your patients, consider the length of time you have to care for them, and your best time management. Some of the research may be indicating that because the modalities can change the viscoelastic properties, in shorter time frames, you can make greater gains by combining your stretching with it. But then they say in some of the research, in the long run, though, you can still get those patients to the same point without the modality, but we know with reimbursement or time, we don't always have as long as we need. So maybe modalities are an option to kind of increase initial gains if we only have a shorter period of time with our patients. Different ways that you can consider how to apply this information for your patients. Either way, what you should draw from today is that the type of stretch you use, when you apply the stretch, and why you're doing the stretch for the patient really makes a difference, and educating the patient to some degree on some of this will allow them to make better decisions when they leave and return to work and sport and recreation, so that hopefully we're not seeing them back for the same pathologies again. Ballistic stretching. Ballistic stretching is what we don't want to do, and that the example would be, let's say I'm stretching my wrist extensors and I go to my end range of wrist flexion passively and then I bounce on it. As I'm bouncing, I'm triggering that muscle spindle to fire, and it's sending the signal up to my spinal cord. It comes back down, telling the muscle to contract. So the muscle's being obligated to contract, and then, the stretch force is telling you to lengthen it, and that can cause trauma and damage to the muscle. So you want to avoid that stretching. Ballistic stretching should not be utilized ever. It's inappropriate because it can damage the muscle tissue. The goal really when someone is performing ballistic stretching is they're trying to perform a static stretch, but their technique is off. So ballistic stretching should never be performed. Looking at passive stretching for spasticity, the static stretching seems to be most beneficial for individuals who are rehabilitating from injury to make those specific range of motion gains, and for individuals who maybe have a previous injury, so that's where they're prone to have an exacerbation or a reoccurrence, that long term, if you want them to continue with stretching, just don't do it right before you're putting a significant demand on that muscle, because it can impair strength for it. So we tend to use that static or passive stretching more in not our neurological case where we have spasticity that we're trying to manage. Good question about the PNF type of stretching and indicated for contractures. So looking at contractures, it's not necessarily contraindicated. Now, with the caveat with that is you have to look at the specific pathology. If active contraction of a muscle is contraindicated or joint motion is contraindicated, then PNF is off the table. Assuming that's not the case, if you have just a contracture, you can try to use stretching, but just know, because it's the joint capsule and ligaments that are also tight, if you only stretch the muscle, you may never really get the full range of motion back. So it may need to be a combo of your PNF stretching with other interventions to stretch out that joint capsule, whether it's modalities or joint molds, or depending on what your plan of care is and your state guidelines. When we look at someone with shoulder subluxation tends to be an overstretching of the structures. So you need to look at where, that's such complicated shoulder subluxation to tackle, but just to mention briefly, you really need to look at that alignment of the scapula, and is it dumping the humeral head out? And why is that happening? If there's low tone, what interventions are going to help you align? And then which structures need to be stretched and strengthened based on that patient's alignment. So sorry, it's not a quick answer. It's a huge discussion, shoulder subluxation. But generally speaking, you do not want to stretch a joint if you don't have good alignment of it, and you can risk damaging the neurovascular structures also. So be cautious of that. Ultrasound, another great question. I can tell you that when applying ultrasound, you need to consider many different variables. There are so many different parameters: frequency, intensity, depth of penetration, transducer size. There are so many different mode. Do you want pulsed or continuous? It's a huge decision. What you want to be specific to is figure out what your target tissue is. Is it the muscle or the superficial joint structures? Set your parameters to reach those structures on that patient, how deep they are. And then if you're looking at it just relative to stretching, you want to make sure that you're using a mode of ultrasound that applies heat. So you're probably looking at a 50% pulsed, or even better, a continuous. So those are some things to consider. The research seems to vary. Somewhere between 6 minutes and 25 minutes is when this potential impairment of muscle performance occurs. So if there's a specific static stretch that someone needs for their sport performance, and they're going to need that same muscle to have power and coordination, you want to be at least 15 minutes out, which just means sequence their routine. Do an active warm-up, do your specific stretch, then your dynamic warm-up, followed by your sport-specific drill and competition. You will probably be okay. But maybe educate that athlete that after they do that static stretch is when they are at a greater risk of that muscle maybe not firing. So don't go do something crazy at that point in time. Be a little more cautious, participate a little slower, know that you may have, be at greater risk for compensations at that point in time. And not to mix in that static stretch during the competition. Generally speaking, based on what the research is saying, that's where it's leaning right now. In terms of prescribing medications, even supplements, that has to be looked at in terms of the practice act in the individual state, and not going beyond our scope of practice. But it might be something to consider with the physician to talk about the other medications they're on. The studies didn't necessarily say to increase the calcium intake for individuals, but just that it plays a role. So again, it might be a dialogue to open up with the physician to see if there's an opportunity there. The nitric oxide tends to, they found that it is what helps initiate the cascade of chemical reactions that allows satellite cells to activate. And ultimately, it's that satellite cell activation that leads to the repair and regeneration of muscle to allow the muscle length gains. So what they're finding is that stretching performed appropriately can contribute to that cascade of events. And that's a significant oversimplification of it for this course, but essentially that's what they're finding in the research now. How they're going to utilize that information in terms of other maybe medication applications, will be yet to be seen. But that's something that's emerging now in the research, that it does play a role. So Elizabeth, asking about static stretching decreasing strength. It is just a short-term effect. The research really varied, somewhere between 6 and 25 minutes, that there was an initial inhibition of the length-tension relationship and other neurophysiologic factors, that decreased Hoffman reflex, things of that nature, around 15 minutes. But because it is variable, that's where, when we look at structuring our programs for return activity in particular, static stretching, they're tending to say that's why it should be post-sport or at a different time, because it is variable in terms of its impact on muscle functioning. And Amy, that goes into your question also, where that where that dynamic stretching really tends to be the better choice before activity participation. For our patients in the rehab setting, then, we're looking at combining our stretching in terms of sequencing. We'll talk about where should it fit with modalities if you choose to use them. So it would be modalities followed by stretching, followed by exercise. And again, we just need to be cognizant of the fact that we're probably using PNF or static stretching in the rehab setting, because that is most beneficial, because those hold times are what's going to initiate all those physiologic responses that we talked about. And then we want to go into exercise after we make the range of motion gains, because we have to teach the patient's muscle to function in that entire range of motion. What you need to consider is balancing demand of that exercise with the fact that there could be inhibition in strength. So looking at quality of movement, quantity of movement, perceived exertion, and just, I guess, it's more of an awareness of that when you're looking at your patient's exercise program. And maybe if you're progressing them in the complexity of an activity or going to a closed chain type of activity, just know that if it's immediately after stretching, you are running the risk of there being some muscle inhibition. So you might want to give that little bit of time in between. And again, some of the research says it's as short as 6 minutes. Others says, it's not that big of an effect. So just factors to consider. How we apply all of this, there's not going to be one specific yes or no. I look at it more as we have the general concepts, and we're constantly monitoring our patients and how they're performing. And this just gives you more ideas of what to tweak to try and max the outcome for each patient. In terms of why is there no stretch reflex with the dynamic stretching, that's a good question. What happens is, with dynamic stretching, the individual is generating the force. So it's not an external force where you can tend to stretch the muscle spindle beyond what's possible, because the individual is generating it with their own force and they're getting more feedback. So I think that it's more controlled and it's just not triggering it as much. And it's because we're relating to the Golgi tendon organ. So the muscle is contracting. So let's say your hip flexors are contracting with those high knee kicks, and then the Golgi tendon organ is sensing that, and it's telling the glute max to shut off. And if you look at the strength of the muscle spindle reaction versus the Golgi tendon organ, the research says that if they're in a battle and one input is going to be recognized by the tissues, it'll be the Golgi tendon organ, which would kind of shut off that contraction, if that helps. What they're finding with the active stretches is that it's not truly a ballistic component, where you're not at end range and then bouncing there. You're going up to an end range and then coming back. So it's different because it's more controlled, and the dynamic stretching is looking at being very precise and quality related. Active stretching is more like the yoga, where you're holding a posture. So I think you're asking about dynamic stretching. And again, it's controlled, it's about quality, and you're not bouncing it. You were asking about stretching, doing triathlons and where to put the stretch. And triathlons are actually a good point, because you're doing the swim first, so you have heating developed, and then you're going into your bike and then your run. The stretching is going to depend on when you need your force, and what you want to pay attention to in this next hour is when we look at the risk of injury that's occurring. And actually, I'll speak specifically about running. It has to do more with a concern over not so much power in a triathlete, but looking more at risk of injury. So I would say depending on the surfaces that you're running on, and then also looking at the impact on perceived exertion is where you're going to see the bigger changes and impact. Good question about the dynamic stretching, how long those benefits last for. And actually the research studies that I pulled didn't speak about that. What I would think is, while you may not have the benefit of them to enhance performance, at least, some of the research studies said that there was, no difference between the dynamic stretch and the control group. At least you don't have the negative consequence of the static stretching. So you're right that, it might be something to think about that person that sits the bench, that they may need a little more stretching incorporated in between in order to increase their ability to participate.